Hi, hope you're enjoying the summit. I'm Rachel Needle, co-director of Modern Sex Therapy Institutes. And Modern Sex Therapy Institutes is a continuing education provider. We provide continuing education for medical and mental health professionals around the world. And we have over 140 archived workshops on our website, so please check them out at www.modernsextherapyinstitutes.com. Also, we have a number of certification programs, including sex therapy, couples and sex therapy, LGBTQIA affirmative therapy, alternative relationships, transgender mental health care, medical sexology, sex education, and sex counselor certifications. In addition, we offer a PhD in clinical sexology. So please, again, go to our website, check out everything that we have to offer. A lot of our stuff is available solely online from the convenience of your own home or office. We do things live in 8 states and live via webinar as well. I can be reached at rachel@modernsextherapyinstitutes.com or 561-379-7207. Again, that's www.modernsextherapyinstitutes.com. Thanks so much for being here.
Hello, everyone. My name is Michael Vigorito. I'm a licensed marriage and family therapist, certified group psychotherapist, and certified sex therapist. Private practice in DC, where I provide individual, group, and couples counseling with a specialty in working with men concerned about sexual behavior problems and out of control sexual behavior. Also a consultant in the Washington, Baltimore area, where I train behavioral health providers and behavioral health agencies on integrating sexual health into routine care, as well as culturally competent practices for sexual and gender minorities. All right, so that's a little bit about me. So today, I'm just going to be giving an introduction around working with out of control sexual behavior, primarily just to help you think critically about times when a client might come in and self-identifying as being a sex addict, or identifying that they have some sexual behavior problems that they want to address, or maybe you have a client who thinks that their partner might be a sex addict, or they've discovered that their partner has not honored their sexual agreements of the marriage, or they discovered that they have a solo sex life that is troubling to them and are wondering if maybe their partner is a sex addict. I want to help clinicians think through those moments and think critically about how to address it. Because, what often goes unsaid is how we conceptualize this problem will affect our ability to provide effective treatment and ethical care. Right. So that is my hope for the next 30 minutes with you today. Some speaker disclosures here. I do receive royalties for the publication of my book, Treating Out of Control Sexual Behavior, Rethinking Sex Addiction, which is what this presentation is based on. And it also makes me feel a little more comfortable than just giving you an introduction, because I know the information is out there in the book. So if you want more information, it is there. You can also email me if you have any questions. All right. Here are my objectives today. We're going to probably touch on most of these, but primarily around talking about a non-pathological conceptualization to out of control sexual behavior. I want to define out of control sexual behavior and talk about why I use that phrase and how I use it. And then at the end, apply a set of sexual health principles in the assessment and treatment for sexual behavior problems. Okay, where are we? In my notes. Okay, what I want to do is just give you just a quick snapshot of the literature. And I want to summarize 4 primary conceptualizations for sexual dysregulation that are it's in the literature, and then tell you at the end why I primarily view this as a psychosexual problem. Right? You're going to also hear me some define terms, just so you kind of have a shared language about what it is that we're talking about. So the first one is, what do I mean by sexual dysregulation? This is kind of just a large umbrella phrase that I use when talking about this concept of actual or perceived lack of sexual self-control, right? And then the literature has been trying to figure out how to understand that issue, try to develop maybe a set of etiology or a set of diagnostic criteria. But just using that as the umbrella term, and then we're going to get more specific about the different phrases or labels that people are being using to discuss sexual dysregulation. So the four conceptualizations that are in the literature are pathology-based models. Here, researchers and theorists are trying to identify a pathological etiology or a set of diagnostic criteria to include in our official psychiatric nosology in the DSM-5 or the current ICD-10. The second conceptualization kind of bedevils the first, in the sense that the second conceptualization is this issue is really just a symptom of a pre-existing medical condition or psychiatric condition. And I'll talk about that in a second. Third, it is what the research has been calling moral incongruence. And here, let me catch up. We're talking about having a values conflict about one's sexual behavior, right? That we're engaging in this behavior despite the fact that I might find it to be morally reprehensible. And what is interesting is really looking at the consequence of the narrative that the client develops around that problem, which can be the source of the psychological distress rather than the sexual behaviors themselves, which we'll get into. And then lastly, a psychosexual problem, which is just a constellation of either intra or interpersonal factors and the social cultural influences around sexual behavior and the choices that people make. All right. Now, I always feel bad going through this because it's kind of like almost like speed reading, or because really I'm just like a skipping rock on this lake of a lot of information. But I'm just going to be touching on a couple of things. But if you do want more information, yeah, it's out there. So here are the primary pathology-based models or disease-based models that are trying to describe and understand sexual dysregulation. The first and the most popular is around sex addiction. Now, in sex addiction, this is applying a substance addiction etiology to sex, right? And that there's a lot of problems with that, but I want to highlight a couple things around that can be problematic. One, it's difficult to do that because there's really not a standardized definition of addiction in general, and there's definitely not a standardized definition of sex addiction in particular. However, there are features of an addiction that are typically understood to be included here, that we're talking about a compulsion to seek a drug or the drug the person is addicted to, a loss of control over consumption, withdrawal, or the neurological adaptations that develop over time that promote craving. Right. So if we're just looking at some of the general criteria around substance addiction, these are kind of what typically shakes out. And there's insufficient evidence that has emerged to support applying these features to sexual dysregulation. With compulsive sexual behavior and impulse control disorders, again, we need to define some terms for a quick second. We're talking about impulsivity here. That is behavior that's driven by desire to obtain gratification and pleasure. Compulsion is different. That's a behavior that's an attempt to alleviate discomfort or anxiety, right? Now, again, the research shows that impulsivity can be an important factor, but does not fully explain the variety of sexual dysregulation presentations that come into our offices or that have been identified in the literature. And few people engage in that rigidly followed, rule-based sexual behavior that's inherent in conditions like OCD or other anxiety disorders. Now, in the ICD-11, which is not the ICD that we use, an International Classification of Diseases. Currently, we use the ICD-10 in the United States. That's paired with the DSM-5. But the World Health Organization has passed the ICD-11, and it includes a classification for compulsive sexual behavior disorder. Now, there's some important things to mention about this. One, if I mentioned earlier around the difference between impulsivity and compulsivity, right? So this disorder is in the impulse control disorder family of the ICD-11, which to me already creates a bit of tension. But there's some important rule-outs within this classification that are important to understand because they're also trying to prevent overdiagnosis. So it excludes things like if someone comes with a paraphilic disorder, or if it's a symptom of another psychiatric condition, or there's distress related to the sexual moral conflicts that the client has around the behavior that they're engaging in. And to me, that is like the other buckets that we were just talking about. I'm not sure what is left, or if we exclude all those, particularly for the clients that I have seen, most of my clients fall in those three exclusions. All right. So that was a speed reading through the summaries of pathology-based models. But let's take a look at the second conceptualization. And we're talking here about sexual dysregulation being a symptom of a pre-existing medical or psychiatric condition. Now, I mentioned earlier that what is bedeviled our ability to identify a discrete sexual behavior disorder around sexual dysregulation is how regularly people who present with that condition also meet criteria for other psychiatric conditions, such as ADHD, depression, bipolar disorder, have drug and alcohol addiction, right? And the theory being, if we address the underlying psychiatric condition, many times the sexual symptoms will remit, right? So we have to be careful that treatment that misidentifies sexual dysregulation as the target condition instead of a symptom of the existing disorder will be, one, less effective, but two, risks an iatrogenic injury, right? So again, defining term, an iatrogenic injury is relating to an illness that's caused by the medical examination or by the treatment itself, right? It comes out of the medical world where before we knew anything about germ theory, surgeons would go in before washing their hands, right? And so that bacteria was then inserted by the treatment itself and then creates this infection that ultimately kills the client or kills the patient. The analog in psychotherapy is inserting a disease narrative where one might not exist, right? And that disease narrative can have its own negative psychological consequences. I mean, think about the identification or identity process that one goes through when they identify that, oh, I've got bipolar disorder, or, oh, I'm addicted to alcohol, right? They have to grieve who they thought they were. They have to accept this new condition and then accept the change in their life to be able to address whatever psychiatric condition that they have been diagnosed with, right? We do not want to prematurely push someone through that process if there is no psychiatric condition to begin with, right? Okay. This third bucket around moral incongruence, again, this is when you're engaging in a behavior you believe is morally wrong, right? And there's a variety of reasons why people might engage in behavior that's morally wrong. When it comes to sex, one of the primary reasons was, one, it probably feels good, right? There's a motivation to engage in this thing because it feels pleasurable. It might feel better than whatever it is that they were feeling before. So you can see the motivation to get curious about what that is. But if they have a values conflict about the particular ways in which they're trying to feel pleasure, that incongruence, that moral conflict creates a lot of psychological distress for the person, right? So this moral incongruence has been strongly associated with a person's perceived sex or porn addiction problem, or the perception that, oh, I am a sex addict, right? And a substantial predictor to that moral congruence is around religiosity, right? That the sexual behavior that I'm engaging in, that I find really pleasurable, is at odds with my moral values, is at odds with my faith journey, is at odds with the teachings of my religious institution, right? And what's been interesting is when we look deeper into those clients who are concerned about being a sex or porn addict and have that moral congruence, is the perception of having that sex addiction was not indicative of actual sexual self-control problems, right? They weren't scoring worse on measures of sexual self-control, right? But they were just identifying when they did cross that boundary internally, they were identifying that as an addiction, right? One of the things I recommend people to do is, like, when people say, oh, I'm a sex addict, right? If you have to ask questions about frequency, intensity, what's going on, it's not uncommon for someone to say, for instance, I'm a porn addict. And I was like, oh, well, how often do you look at porn? I'm like, oh, well, once a month. I'm like, okay, tell me more about now. Why do you think that frequency is indicative of addiction? I want to get curious about that. Now, whenever I'm saying this, I always want to make sure that people understand that I'm not saying that a client doesn't have a problem or is not pained about this issue, right? what I want to do is get curious about it, right? And allow the space to, allow the therapeutic space to be open for the possibility of understanding the functions of that behavior. Now, when we introduce and assume that this is based on addiction, we kind of stop being curious and then start providing treatment, right? So it's kind of like a patient going to the doctor's office, and the patient's like, "Oh, doc, I think I've got cancer," and the doctor's like, "Well, thanks for telling me. I don't have to run all these silly tests. Let me just provide the treatment," right? You know, we want to be able to provide a curious space to understand and get clear on what the frequencies are, what the intensities are, and what the function of this behavior is, right? And not to make the assumption that because the client thinks that they're a sex addict, that they actually are a sex addict, or that we want to provide treatment that's based on addiction until we understand the underlying issues that are present. Now, if there are any rational emotive therapists out there, what I think about this conceptualist that I really like, that it's familiar with some old thought around the origins of emotion, right? The ABC theory of emotionality, where people think that A, the antecedent, is what creates C, the emotional consequence, but there's a B in the middle, and that's around belief, right? So the belief about A is what creates C. So if I believe that my behavior is pathological, if I believe that my behavior is addiction, I'm going to have the emotional consequence based on that belief that's going to create some of the distress. So the shift then is around understanding the client's value system and trying to understand the contradiction between, all right, this is your value system, but this is what your behavior is. And let's get curious about that contradiction. All right. And lastly, it's a psychosexual problem. So on the spectrum of sexual distress between sexual worries, problems, and disorders, right, where sexual disorders are a very narrow portion of the population. It's the disease criteria that has official consensus in the literature and affects a small and narrow portion of the population. On the other end of the pole is sexual worries that, it's a worry that everyone can understand and agree to, or everyone can relate to. I mean, for instance, am I a good kisser? Or do I look good in this outfit? Or are we going to have sex today? Or is this going to be fun? Is this going to be good? Am I good? The universal concerns around sexuality. Now, there's this middle that's kind of more uncomfortable, this diagnostic gray zone. And this is where I think sexual dysregulation falls, right? There could be a psychiatric disorder that's embedded in it, right? As I mentioned before, it could be a symptom of bipolar disorder, a symptom of depression, but in and of itself, this sexual behavior is more of a problem rather than a disorder or kind of a universal worry that people have. And one of the reasons I like thinking of this as a psychosexual problem is that it recognizes that people can still benefit from treatment and improve their sexual health without the imprinter of a psychiatric disorder, right? That they don't need a disorder or a diagnosis to change behavior, but they do need motivation. And I come from a motivational interviewing background, so I'm always listening for the internal conflict, the self-discrepancy around the behavior, so I can understand the function of what that behavior has been trying to do for them. Because it might be a solution to a bind that in therapy we can help hopefully find another solution to help address that bind. And it also allows clinicians to consider the variety of ways in which the sexual behavior can be problematic, all the heterogeneous origins and the presentations of sexual dysregulation. Not one client is typically the same, right? So I need to understand all of those inter and intrapersonal factors, as well as the social cultural factors that influence their sexual choices that are going to be unique to the client, right? Okay. Oof. We're doing it on time. All right. So I just sped through a lot of information. Hopefully, just to land on the point, thank you, Rachel, for laughing at me, that I typically recommend taking a look at this behavior when it presents itself in these last three buckets, right? We got to understand, is this a symptom of a pre-existing medical or psychiatric condition? Is there a moral conflict that is involved that can better explain the distress that is experiencing with the client? And then 4, looking at all the potential factors that could contribute to sexual dysregulation, right? Particularly, as you heard me say, to get curious about the client's motivation. One, getting curious about their motivation for change, but what has been the function of this behavior? And they're typically trying to solve a problem with it, and I want to know what that problem is and see if we can find another solution. Okay, so now let's just talk about out of control sexual behavior and kind of why I use this term and how I understand it. All right, so how I define this phrase. And this phrase, out of control sexual behavior, was recommended by John Bancroft and Bogdanovich in research about 15, 20 years ago when they were trying to figure out, it's like, all right, is this a diagnostic criteria that we're trying to isolate, or is this a sexual behavior problem? And in that, we just need a phrase that doesn't assume etiology or is not kind of prematurely advanced in a psychiatric condition before the science is there. So they've recommended a descriptor like out of control sexual behavior to be almost like a placeholder for clinicians and researchers to maintain their curiosity about what's been going on. But that also didn't tell me, when Doug and I were writing this book, we're like, well, we need to define what that means and how we're using that phrase, right? Because in and of itself also has some problems. So this is the definition that we use. That out of control sexual behavior is a sexual problem in which an individual's consensual sexual urges, thoughts, or behaviors feel out of control. So let me break this definition down a little bit. So I talked a little bit already about a sexual health problem, right? It's not a sexual health disorder. It's not a sexual health worry. It's in that uncomfortable diagnostic gray zone of it as a problem. Now, you may have already been hearing me talk about this, but I've been using the word, or I've been gendering the clients typically because I primarily just work with men, mainly because that is the population of folks who are coming in to see me about this issue. Doesn't mean that this can impact women or people along the gender spectrum. However, I've been gendering just to kind of stay in my lane because this is typically the population that I work with, right? Consensual. This is one of the clinical distinctions that I make around this particular issue, that the people that I'm addressing and treating are all engaged in consensual sexual behaviors, right? People who are engaged in non-consensual sex, I recommend that they seek treatment for people who have specialization in that population, right? There are particular ethical conditions. There are concerns when working with that population. There's the ethical tension between providing effective treatment, but also maintaining public safety that I think the clinician needs to be aware of and versed in, as well as the factors that contribute to engaging in non-consensual sex are a bit different than some of the factors engaged in consensual sexual problems. So I think that specialty or that client should be treated with someone who has specialized training in working with that population. So the people that I'm talking about moving forward are all engaged in consensual sexual behaviors. Sexual urges, thoughts, and behaviors. These are the components of sexuality that I want my clients to be better versed in and know that these are distinct and different things. An urge is that feeling state of wanting to be sexual, that kind of moves us in that particular direction, right? Thoughts are the cognitions, the fantasies, how people are thinking about, planning about sex, and then behaviors, the observable actions that people engage in when they're sexual. And then feels out of control. This is where I think the definition pivots. It is where it is distinct from the pathology-based models, is that here we're just talking about a person's subjective internal experience, right? That they feel out of control for some reason, and it's my job as clinicians to get curious about what does that mean to them, right? And how I typically understand it is that the client is typically of two minds about this behavior, right? That there's some internal conflict around the behavior that they enjoy, that brings them tremendous pleasure, as well as, or conflicting against some vision that they have about who they are, against the values that they have, or against the commitments that they have made in their relationship, either around partner sex or solo sex. In that there's a set of competing motivations within the client, and it is that tension, is that wrestling, that is what they're talking about when they say they feel out of control. Now, they may use other metaphors to describe it, like, oh, that's my addict brain, that's my addiction talking, right? And I want to kind of move out of some of that pathology-based language to get curious about what does that actually mean to them. And typically what I'm finding is that they're typically talking about this moment where they have this tension, this competition between the short-term gratification and this long-term goals that they have, right? The short-term gratification, I don't want to feel depressed right now, or I don't want to feel anxious right now, right? But how I'm doing that might put me at risk for an STI, or it might put me at risk for losing my job. But those are longer-term consequences. Right now, I would really like to not feel anxious, right? And they engage in that behavior, and then afterwards feel a lot of shame, guilt, and concern about now I may put myself at risk for an STI, or put myself at risk for losing my marriage. And is that repeated tension that they're calling my addict brain, or what I would say is the moment where they feel out of control. But what's important is that this is a subjective experience, right? And it's their assessment. It's not me labeling them as being out of control. It's not their partner labeling them as being out of control. It's their subjective experience. And what's also important to remember is that even though someone might feel out of control, as Maury Klein mentions, doesn't mean they actually are out of control, right? And it's our job to get curious about those moments when, all right, this is when you feel out of control, okay, but I also want to know, why did you stop? Why did you redirect your behavior? When did you redirect your behavior? Tell me about those decisions, because you are not engaging in this behavior all the time. You do actually go to work, or you are raising children. It's just in these pockets where you have some opportunity where this behavior surfaces, right? Well, that's interesting. How come it's not present over here? So it's also a way to develop confidence that they do have some control, and they're exercising that in some ways. And we can hopefully expand on that and get curious about the times where they do decide to exercise control or when they don't. Okay. Rachel, can you time check me? How am I doing?
You are doing just fine. You have about 5 minutes left.
5 minutes. Woo!
Take longer if you need. I think everybody's enjoying it.
Okay. Well, hopefully. Okay. So the one phrase that I kind of stepped over was this concept of sexual health, and kind of what I mean by that, right? And this will then introduce the sexual health principles, and will bring us to a close for today. All right. So the definition of sexual health that I use comes out of the World Health Organization's working definition of sexual health. And I can also forward these slides, Rachel, so people have this information, if that's helpful. So let me highlight what I think becomes the central tension of sexual health. So you can see this definition here, right? And it's trying to expand it just beyond the absence of a disease or infirmity. It's also talking about this positive, respectful approach to sex and sexuality, and it's free of coercion, discrimination, and violence. But if you kind of move through, you can kind of see some of the principles that they're working on. And one of the things I like to highlight is this becomes the central tension of sexual health conversations, where we're trying to help client balance their desire to have pleasurable sexual experiences and be safe at the same time, right? So this tension between pleasure and safety, to me, is at the root of sexual health conversations, right? And the tension that people are experiencing. And then lastly, as our job, as providers, we want to make sure that we are protecting their sexual rights, right? Because clients have the right to sexual expression, and they also have the right to be free from sexual discrimination, and that can also be from the provider. So the set of sexual health principles that I promote with my colleague Doug Braun-Harvey is our way of helping providers protect clients' sexual rights, to help them engage in sexual behaviors that are pleasurable and rewarding, fulfilling for them, but also manages that tension around safety, but keeps it away from the therapist from promoting what we think is the right type of sex that they should be engaging, right? Because that is not our job. Okay, so there's a slide that's missing here. So here, there's the definition. Let me see if I escape here. Okay. There's a paragraph here that got whited out that comes out of the World Health Organization's definition and Pan American Health Organization's discussion around sexual health and responsibility. And within that, there is a set of principles that Doug highlighted and became the foundation for our 6 sexual health principles. So when I pass on these slides, Rachel, I'll make sure that that paragraph is in there. So for me, it's important that we show our work. So I don't want you to think that these principles were just the brainstorming of 2 psychotherapists in Southern California when I was out living there. That these comes out of a consensus discussion from public health providers and medical providers around what is sexual health. And so the principles that I think are important in that discussion are what can be used to help clinicians think critically about how to engage and why, right? So the first being that this is consensual, that everyone's engaging in this sexual behavior in a way that they are consenting to be there, right? Being in that's partnered sex, but it also could be around the sexual entertainment that people are looking at. So I carry forward that this principle, even when someone is saying, I just engage in solo sex, well, tell me more about it. What is it that you're viewing? And when you're thinking about the entertainment, is everyone of the age of consent that you're looking at? And is everyone consenting to be recorded and displayed, right? If not, then there might be a non-consensual element in their erotic orientation, and that may mean a referral to a non-consensual specialist, right? The next principle, non-exploitation, that is someone leveraging power and control in order to have sexual access and sexual gratification over someone else, right? The Me Too movement is a reckoning around sexual exploitation, but it doesn't have to just be around rich, powerful movie moguls exploiting actresses to be considered exploitation, right? It could also be around someone who's homeless and someone offers like, well, I'll give you shelter if you perform oral sex on me, right? Any type of power that's being leveraged in that way to exploit someone else, right, is outside of the bounds of what we consider sexual health, right? So we want to get curious about how people are using power in order to have sexual access or gratification. It's protected against STIs and HIV and unintended pregnancies. And this is one of, I think, the original definitions around what sexual health is. Back, before the mid 70s, if you didn't have the clap, you weren't knocked up. You had sexual health. You're like, woohoo! But luckily, the World Health Organization started thinking more critically around. All right, I think there's something more to this concept around sexual health. That's not just around the absence of STIs and unintended pregnancies, but it's still an important factor to be considered and screened when people are coming in with sexual behavior problems. And then next one is around honesty. So this is both interpersonal and interpersonal, right? Am I honest to myself about the things that I enjoy, that bring me pleasure, that I want to engage in? And am I honest in communicating that to other people, particularly my sexual problem partners, about what I like and what I don't like? I think both of those concepts are just as important, communicating what I like and communicating what I don't like. Shared values. So sex is all about meaning making, right? It could be recreational, it could be procreational, and it could be relational, right? And are the values that the person has overlapping with the person they're having sex with? Are they both engaged in sex in a way that is consistent with their values, right? And is there overlap there? And then lastly, is it mutually pleasurable? Is it pleasurable for me? Is it pleasurable for you? Is everyone's pleasure in this sexual encounter being considered, right? And one of the important things about this piece is this can be the most tricky part for clinicians to really focus on and delve into. We don't necessarily see ourselves as talking about sexual pleasure as being important. But again, if you remember what that central tension around sexual health is helping them manage safety and pleasure. We are so much more comfortable talking about the issues of safety and risk avoidance than we are about talking about pleasure and sexual pleasure promotion. But if we don't talk about that, we're only working on one side of the equation, and we miss why people are engaging in sex, what they're motivated for, and also an ally in overall health and well-being, right? People talk about sexual pleasure as being an important part of their lives, about how it can improve, sex can improve relationships after conflict, or it can be a helpful ally in managing our mood or just bringing color to life, right? So we want to make sure that we look at sexual pleasure not just as something um, to be concerned about, right? But also something that can be a force for good and an ally in the overall health process, right? Or therapeutic process. All right. I think we're hitting on time, correct?
Yep.
All right. So one of the things I just want to wrap up with is like with these sexual health principles, notice that these are not act centered, they are principle centered, right? I want to make certain that we see this as kind of an ethical code that we're also helping our clients to integrate so that when they leave us, right, they can then use this set of principles to start making decisions. And once their behavior is within this framework, then the details are really up to them. And if they can keep their behavior within this framework, it's very unlikely that they are feeling out of control at that moment. But when they start bumping up against some of these principles, that's when we get more active and involved and get curious about what they're trying to solve for, but help motivate them to maintain their sexual health within these parameters. And can be a great source of conversation and motivation for clients to achieve their sexual health. But the preparation starts with the therapist, right? To be able to be ready to facilitate sexual health conversations that can focus on pleasure, to be mindful of our own biases that can be present in the times where we feel uncomfortable about this, because if we feel uncomfortable having these conversations, it'd be hard for us to facilitate these conversations with our clients. And the ethical standard of care here we're talking about is what I mentioned earlier, is honoring their client's sexual rights. They have the right to be to sexual expression and the right to be free from sexual discrimination and bias, and that includes the therapist. So this is a way that I help therapists check their biases and understand why they are intervening at this time, right? And it's a way that I help my clients protect their sexual rights, as the World Health Organization has deemed relevant and important here. Okay. Whew. 30.
I am so excited to be here with all of you at this first amazing sex summit. So welcome, and I'm glad you are in this workshop with me today. I'm really grateful, actually, that each and every one of you is in this workshop, because this topic is so important. When we start talking about kink and BDSM and shame and how do we as clinicians take care of our clients, it's just, I think it's one of the most important things we do, because I think on this subject, our clients are so tender. So I'm glad you're here. Therapists can do harm in many ways, and I know that's never anybody's intention. And one of the ways we make sure we don't do harm is education and training. So off we go. I thought I'd start with just sharing a little bit of context for this particular topic. And part of that context is I can't tell you how many clients have told me over the years how they have been judged, shamed, or refused care even by their previous therapist. And so to just kind of shine a spotlight on what that actually looks like, I'll never forget, it was a really hot summer Sunday. My office line forwarded to my cell phone. I answered the phone as I generally do. And it was a woman on the other end who wanted to become a client. And I could tell she was really upset. And so I just asked her, a couple really simple questions. But what had happened is the reason she wanted to come in and see me right away was because she was in individual therapy. She told her therapist on the very first session that she was identified as kinky and as a submissive. And the therapist said, okay, that's fine. And then when the client would try to bring it up, the therapist really kind of avoided it. So by the sixth session, the client really wanted to talk about it because there was a pending thing coming up in her life that was important related to this. And so she asked the therapist, we talk about this, it's so important to me. The therapist said yes. 20 minutes into the client talking about kink and being a submissive and what she wanted from her dominant male partner was a response from the therapist was, I can't work with you anymore. I can't not work with a woman who would subject herself to domestic violence and abuse. The client was crushed. She was in a consensual BDSM kink relationship, and it really broke her heart. As she was telling me the story, she was sobbing by the end. So that's the kind of stuff that happens, and that's the kind of stuff we all want to make sure we avoid. So let's just talk a little bit about what we're going to talk about for the next 30 minutes. We're going to do some really brief definitions. I just want to get your expectations kind of all set up. We're going to talk pretty quickly on just some fast facts and research. We are going to delve into some different kinds of shame and make sure we all understand that as it relates to treating kinky clients. And then really most of the time, the whole second half, we're going to focus on tips and steps towards becoming a kink competent therapist. Today's session will not by any stretch make somebody a kink competent therapist, but there's steps, and everything starts with a step, just with our clients. So kink's the umbrella term for BDSM. And BDSM is bondage and discipline, dominance and submission, sadism and masochism. 6 words for 4 letters. And here's just some fast facts about BDSM practitioners that you might find interesting. So first, there's no elevated psychopathology as a group. We know that from multiple studies. In my study in 2009, we did MMPI-2s on N equals 141, and that was the result. That was our findings. And interestingly, and why this is so important for therapists to think about is because when I wrote my doctoral dissertation, I was at a cocktail party and there was a psychologist there who asked me about what my dissertation was on. I told her it was a psychological assessment of BDSM practitioners, to which she responded, oh, well, I know the answer to that. And I said, oh, really? Tell me, because that would save me a lot of work. And she said, oh, well, they're all sick. Like, really? So that's the belief that sits with a lot of clinicians. And so part of what we're here to do today is like dispel these myths. The other thing we learned from the Merritt study is the IQ of BDSM practitioners is significantly higher than the general population. And it's not really surprising if you think about it, because BDSM tends to be, there's lots of different ways it takes shape, but part of it's just a really intense, adult, sophisticated role play. So of course they're smarter. The other thing is, from Dr. Mosier, we've learned there's no evidence of elevated levels of childhood abuse in BDSM practitioners, and that's another myth that kind of permeates with a lot of people in general. Perpetuated, by the way, by 50 Shades of Grey, right? Because that was kind of part of the storyline. The other thing that just kind of think about it from who's interested in this? Well, a lot of people, right? 10 to 50% of the population, depending on what study and how you want to define BDSM, has participated in some kind of BDSM play. And then we all know 50 Shades of Grey sold over 125 million copies, translated into 60 languages. So yes, there's the smaller subcultures, and then there's this huge level of interest from people that are just turned on by kink. So I wanted to kind of go to this place of, what kinky clients say about their therapists. Let's start with that, because it starts to build more of a foundation. So in the Kink Health Survey that was done just 4 years ago, it's on the TASHRA website. Thank you, Dr. Anna Randall. Thank you, Richard Sprout, for doing this great work, and others. But here's some of the things my therapist said. My therapist said, your desires are deviant and unhealthy. My therapist said, what you do is against my religious beliefs. I don't think we care about our therapist's religious beliefs. My therapist said, your fetish could be redirected to a more appropriate sexual response. I love this one. My therapist said, make sure you're also having vanilla sex. My therapist said, I won't work with a trauma survivor who is practicing BDSM. Well, let me tell you, I'm a trauma therapist. I do EMDR. I work with people who are trauma survivors and practice BDSM all the time. We need to be careful. We need to make sure people's cups aren't overfilled and all that good stuff. But that's just part of doing trauma therapy for anybody. My therapist referred to masochism as psychosis. And then this is a really common one we hear. I had to train my therapist and it got tiresome. So by the time we're done today, no matter where you are on understanding how to treat kink, your client's not going to have to train you. You're going to be trained. I think it's important to just think about like, well, what is on the mind of clients when they come in for therapy and they're kinky? Well, for one thing, they're afraid they're going to be shamed by their therapist. That's not usually the word they use. It's the word we use, but they'll say they felt judged. They'll say they didn't feel accepted, and that's what they're afraid of. They're afraid of being referred care or being referred out, right? And then how does that make you feel if you're referred out? Because you're just too kinky for a therapist even. You're too weird, right? That's a horrible, harmful thing. And then they're also, they're afraid their kink will be used against them, right? So how does that show up? Well, it shows up. It shows up in security clearances. Like here in Colorado, we have a huge industry around that requires security clearances, defense industry and such. And also other clients are concerned that what they say in therapy or in couples counseling will be used against them in child custody cases if they're open about their kink. So there's lots of different layers to this. And as a couples counselor, right, we know that one of our big roles as a couples counselor is to keep balance in the room, to help both people feel equally accepted. But if you're a kinky client and you have a non-kinky spouse or a vanilla spouse, then that kinky client is worried that the couples counselor will take the side of the non-kinky client. And when we say vanilla on a definition level, vanilla just means non-kinky. It means vanilla, regular, everyday stuff. So let's start to talk a little bit about shame. So I've always had this belief since becoming a sex therapist 15 years ago or so that, we all know all roads lead to Rome. Well, when it comes to sex therapy, I think there's this piece that all roads lead to shame. And when we as clinicians can help our clients with shame and heal from shame and change their relationships with shame, I think we can make a big difference, a positive difference, in the way we impact people's lives. So we'll just kind of sit with that. And then let's just talk about this briefly, the difference between shame versus guilt. The way I think about it is guilt is what we did, but shame is about who we are. And then there's different levels and types of shame, right? So there's clinical shame. And my working definition for clinical shame today, for the context of this talk, is it's when a therapist makes their client feel shamed or judged. That's clinical shame. And the parallel that goes with that is oftentimes when that happens, it's because the therapist hasn't fully worked through their own sexual shame. So it's just a good thing to know. It's a good thing to get supervision around. It's a good thing to get peer consults around, talk to kink competent therapists. And it's also a great thing to have to do your own individual therapy with. I'm a huge believer. Every therapist needs to have a therapist. And then there's ordinary shame. And that's just like the negative comparison of the self's actions with the self's standards. That's just kind of everyday run of the mill. Most people sit with some level of shame around something, right? It's the parts of them that they hide. We know if we're keeping secrets, that chances are there's a shame component. And then there's toxic shame. And toxic shame is that thing that eats at the soul. Whether the person knows it's happening or not, toxic shame is damaging. It can damage self image, it can destroy one's sense of self. So when toxic shame is present, we really have our work cut out for us. We need to pay attention and really help folks with that. And then there's erotic shame. So erotic shame is that intense arousal, and generally in the context of erotic shame from something related to humiliation. And then that also means erotic shame is completely dependent on context and intentions, right? So in real life, most people don't want to be spit on. But in the context of sex and humiliation, for somebody where that's a turn on, it's part of their fantasy life, it's the things they like to read about or look at, then it's intensely arousal. Don't spit on me in public. Don't spit on me walking down the street. Don't spit on me if we're at the grocery store because it's out of context. But then, on the other hand, for some people, spit on me in this special situation in this role play. Oh my God, that's erotic shame. So it's a double-edged sword, right? Out of context, horrible. In context, awesomely sexual. That's erotic shame. So we're about the halfway point. So let's roll into what do you do with it? Tips for working with kinky clients. So I think there's like 5 tips that have to do with intention. So in kink competent therapists, I think there's always this active intention to never shame a client. I know that for me personally, that's like one of the mantras that rolls around in my head. Never shame a client. So when I get to this place of a choice point, which we all do, choice points are when we're in therapy, client says something, we have a choice. We can either go in this direction, we can ask a question, we can reflect, right? We have lots of different choice points. So I will always choose the choice point that's not going to shame a client, even if it means I have to like back off of something that seems important. I've got to take the time sometimes to figure out how do I get there if it's important, but not do this in a way that might accidentally, inadvertently shame the client, no matter how well intended I am. So that's one. I think another thing we see in kink competent therapists is they're really good at creating a safe social engagement system, right? So that's often called therapeutic alliance. And so it sounds so simple, but when we think about the trepidation that the kinky clients come to therapy with, and that fear of being shamed or judged, then it just speaks to how important it is for us to be patient, to go slow, to do the little things we can do to help the clients feel safe. I'll give you some examples of that in a bit. And we're always creating a safe social engagement system, right? Whether we're in session 1 or session 20, we're creating a social engagement system. Every minute at every therapy session is our work. That's what we do. And then the third thing for kink competence therapists is, I think we're just really curious, right? We come to this place from just a place of curiosity, wanting to understand the uniquenesses of each person that we have the honor of sitting with in our room. And then I think another one is, we really focus on normalizing rather than pathologizing. And that's really different than minimizing. So if a client's in pain around or conflicted around or whatever it is with their issue that we're working on or that's sitting with them that is poking at shame, we don't want to minimize it. And sometimes we want to normalize it with words But sometimes we just want to normalize it with being willing to have this real easy conversation about complex subjects. And we see strengths. We don't see pathology. And that's important. And then we join. Well, what would be an example of joining? Well, joining for a kink competent therapist might be a client went to a party Saturday night and it was a kink party and they had a great time being spit on, if we'll just stick with that analogy. And so to be able to join, what did you love about that party? What did you love about being spit on? What was the best part, right? That's joining. So this is one of my favorite little cartoons. It's just so simple. Don't ever be ashamed of loving the strange things that make your weird little heart happy. And we say that with love and joy and happiness. So moving into just some philosophical things and other tips, I think one of the things that really helps kink competent therapists is that a lot of us definitely tap into parts of humanism. And that part of humanism that we tap into, it lets the client self-determine the direction of their life. I truly sit with clients and I don't know what's best for people. Only the client knows what's best for the client. So when we bring in this part of humanism into our work as a guiding force, it takes the clinician out of the business of judging. We don't have to decide what's right for our client and what's not right for our client. Right? That story I told when we started, that therapist had made a judgment that what that client wanted to do was not okay. The therapist knew better than the client. So I think when we get ourselves out of the business of judging, I think our clients do better, and I think we do better. Erotic templates are a great way to normalize sex. It's a great way to normalize kink. I will sit with my clients when the time is right. And by the way, this is a good way to build a safe social engagement system early in the process. Somebody says they're kinky, and it's just like, oh, well, everybody has an erotic template. They're like thumbprints. There's no two that are alike. There's not one that's better than another. Erotic templates are just what turn us on and what turn us off. Sounds like kink is an important part of your erotic template. And, for clients that are kind of concerned and trying to feel safe, that's just a nice way, like, oh, okay, I'm okay. Therapist just said, everybody's different. And it applies, by the way, erotic templates apply to, things like kink. Some people like kink, some people don't. But it's like kissing. Some people like to kiss, some people don't. And just because one person likes one kind of kink doesn't mean they like all kinds of kink. It just means they like the kind they like. And we're going to talk about that in a second, too. So our lens as a clinician has a huge, huge, huge impact on how our clients, what their outcomes look like, right? So if we have a sex negative lens and we see things that are less common, unusual, or even rare sexual forms of expression, if we see those things as psychopathology with that sex negative lens, we'll see mental illness. On the other hand, when we have a lens that's strength based, that's sex positive, that allows clients to self-determine the direction of their life, it leads to better client outcomes. So that's why I think it's important to think about how we're being really intentional with how are we looking at clients when it comes to sexual practices and behaviors and interests and fantasies that are a little more rare, a little more unique. Might even be something we don't understand, we don't get. Doesn't matter. Clients get to self-determine what's right for them. And then one of the good things to just put in the back of your mind is, look, we all have judgments. But when we're working with a kinky client, it's okay to sometimes just learn to suspend judgment. So, like, I don't get And I apply I apply the same thing to me too, right? There's not a lot of sexual things people come in with that I get judgy about. But like I had a client that had done some poaching of animals. And he came in and told me that story. And oh, I had so much judgment. I was so judgy. But I had to go back to my own darn rule, never shame a client. So I sat with him and I let him share his story. And, that was just one part of him. And that's not why he was in therapy. It was just the thing he did. So I suspended judgment in that room until I could talk to my own therapist and a peer and just like process that. So that's what it looks like when we suspend judgment. So remember earlier we talked about some of the things the clients said in that Tashra study. Clients don't want to educate us, you, me, the therapist about kink. But I'll tell you what, clients are more than happy to help you be an expert on them. So client says, I'm kinky, or I'm into this, or I'm into that. The kink competent therapist might just say something like, wow, I got that. I understand kink and BDSM. I can totally support you with that. We can talk about anything you want. I'm just really curious to learn about you and your relationship with kink. And what do you like? And how do you identify? And what is it that you love about your kink? And how long have you known? And when did it develop? And, and are there any parts of it you struggle with? Right? So if clients hear that, it's part of building the safe social engagement system. It's part of connection and therapeutic alliance. It's starting to let them be seen. And the thing to remember in this conversation, and it floats around, nothing's as linear is of course what we're talking about in this way today. But one of the things to remember is for many clients, we, the therapist, is the first person they've ever told about their kink. And so we're holding really special place in their life right now. Some have told sex partners or people online or, whatever, but awful lot of clients really have never talked about kink. So we get to hold that space. To me, it's an honor to be with people who are sharing this part of themselves. So as we just start to wrap up, I want to thank you. I want to share one of my favorite quotes that I've always connected to kink, and it's an old Oscar Wilde quote. The only way to get rid of temptation is to yield to it, resist it, and your soul grows sick with longing for the things it has forbidden itself. And that just always struck me, because I think one of the things I've noticed is I've worked with lots and lots of kinky clients now for a long time, and done lots of trainings and given lots of trainings, is that if somebody's kinky when they're 6, and they like to play cowboys and Indians and lose and be the ones that got tied up when they were 6, and they liked it when they were 16, and they liked it when they were 26, you know what? This is a pretty powerful part of their erotic template, and they're probably going to like it when they're 36, 46, 56, and 66. So I think that's just another nice thing to keep in mind, that if somebody has this kink and they are passionate about it, they love it, they're aroused by it, probably not going away. So then how do we help them integrate it into their lives in a way that brings them joy and peace and pleasure? So I would just like to thank you all very, very, very much. I know the speakers for the rest of the afternoon. I know every one of them, and they are all amazing speakers. So I hope you have a blast and learn from everybody and don't miss a minute. So thank you, and peace to each of you.
Today, I would like to speak with you about an issue that I believe is central when it comes to issues of sexuality and romantic development, and that is the notion of fluidity. And I start this discussion by looking at the question of the nature of sexuality itself, which is sexuality a matter of categories, which is the traditional approach, or is it a matter of a spectrum, which is an aspect that we have not really investigated, especially when it comes to males? Now, there are various ways in which we assess sexuality in the literature among scientists and researchers. There are self-reports, genital arousal, viewing time, brain imaging, eye tracking, and pupil dilation. In terms of arousal, genital arousal, the usual procedure is that the individual sits in a lab box and puts a gauge around his penis, and then he is shown various pornographic images, and the assessment is in what conditions does his penis become engorged. In a similar way, we have the individual in a lab setting in front of a computer, and he watches various pictures of males and females, various attractive poses, and we see how long he looks at each picture before moving on to the next. And that would be a measure of sexual orientation, we believe. There are also brain imaging studies in which the individual is shown various pornographic videos, and we see whether or not his brain in certain areas light up, which indicates arousal. Another more recent innovation is to take a look at the eyes. And there are two measures here, eye tracking and pupil dilation. The individual sits in a booth, watches pornographic videos, a camera is taking pictures of his eyes, and even if he desires to present himself in one way, the eyes don't lie. And even though they may just fleetingly look at one image or another, we know that happens. The second part, pupil dilation, is based on whether or not his eyes dilate or become larger when he's looking at certain images rather than others. Of course, the most common is simply to ask on a questionnaire, on a survey, usually one item, what is your sexual orientation or what is your sexual identity? Unfortunately, these sometimes become interchanged, and in reality, they can measure quite different aspects of sexuality. The response options that we usually give our young men is straight, bi, or gay. And whether these three categories represent their sexuality is a matter of debate. Another strategy is to use more of a spectrum approach, in that you ask the individual to place himself on this line in terms of his sexual attractions to females or to males or to both. And you can give the same kind of a measure in terms of his romantic attractions. Again, totally to females or totally to males or somewhere in between. Now, another technique, which is perhaps one that you would use, is simply asking the individual, how would you describe your sexuality without categories, without any kind of predetermined indications, just simply sitting back and listening. As you will see throughout this presentation, this is my preferred measure. Now, to give you an illustration of this, Woody Cook, who is a model and actor, was asked, what is your sexuality? And he said the following: I'm bisexual. It's something I've known for 3 years. I've always felt growing up that I had all these thoughts and I just shook it off. Then one day, and he went to a party and met some bisexual women and men, a miracle moment where my entire life had been really conflicted and I suddenly realized that was it. We've come to a new age where sexuality is so much less of a thing. I mean, it can still be a thing and a lot of people still care, but there are enough people who don't care. If everyone is really open about it, then there is nothing that the people who don't like it can do. All my friends were really accepting all the time. Dylan, a young man I interviewed, 20 years old, played hockey for a major collegiate team, was a little bit not certain how to categorize himself. And he noted that there are a lot of men that he thinks are like him who occupy what he termed the sexual Netherlands, a region between heterosexuality and bisexuality, which he felt really didn't have a name, though he kind of liked the notion of a mostly straight identity. He noted that other men that he's heard, similar to himself, might say straight but not narrow, heteroflexible, bending a little, bi-curious, or as one man claimed, a dude most of the time. Dylan, for his part, said the following: I've been curious about my attraction to guys. I wouldn't say I was bi or that I wanted sex with guys, but maybe a relationship, guy-guy thing I'm leaning toward. Not sexual intercourse with a guy, though I know it would be interesting. But if the guy is attractive enough, you just never know. And this is the key here, and it's the key to the notion that we will explore in depth here, which is fluidity. That is, one of these categories doesn't fit all of the time in all contexts. So we go back to Woody Cook, now 19, and he further explains his sexuality. The reason I can't choose, so he's no longer choosing bisexual, but he's choosing something else, is because one day I feel it's completely girls and another day I could be thinking about guys. I don't know if it's a gay time of the month, but it changes from day to day. It's very fluid. Love is love. You can be who you want and love who you want. And what's interesting about this is not only is he using the word fluid, but he's using it in the context both of his sexuality and his romantic self. And I think that is critical. Now, when you look at the literature, you can find many different ways in which individuals, young men, young women, describe or identify their sexuality. Some of these include pansexual, which is probably the most frequent today, outside the big three, fluid, queer, genderqueer, questioning, trisexual, bicurious, panromantic, and demisexual. I'm not going today to try to describe or elaborate on all of these, except to note that fluid is one of those, and it's not so uncommon anymore. Now, when you ask these questions about identity, some individuals just don't like any term, and they say, no label, I'm confused, I'm unsure, I'm asexual. Everything, anything, I wish I knew, no comment, and normal. And if you leave it completely open, you get a range of terms, of feelings, and reactions. This makes it difficult for researchers to categorize people who don't pick one of the big three. What category, what line of code are you going to put them in? But if we listen to real people, real teens, real young adults, I think they will help us to understand better about sexuality and what it is inclusive for them. Now, part of this is what I have been interested in for a number of years. I've gone to a big conference in Connecticut by True Colors, and there are roughly about 3,000 young adults there of all sorts of genders and sexualities. And I run a workshop in which I explore issues of identity and what it means to them. So what they do is before the workshop begins, they put on a note card their biological sex and their age. And then I simply ask them the question, please, how would you describe your sexuality to yourself or to your best friend? A 14-year-old said, bi, get with it. Another 14-year-old said, I like boys. Note, he did not say gay, but I like boys. Another, I am probably straight, but I am questioning. I am open to anything. I often find myself attracted to guys, but more so to girls. I've experienced sexual and romantic attractions towards men and women. This is a very key quote because it notes the questioning of one's sexuality and one's romantic desires. A 16-year-old says, I don't desire to identify my sexuality. I just am me. Get over it. And I think this last phrase, get over it, is intriguing because some of the youth are not particularly happy with adults asking them personal questions about their sexuality and romantic desire. So you have to make sure that you have sort of a good rapport with them before you go too far into this, if they're going to be totally honest and explicit with you. A 17-year-old said, straight, but maybe I haven't met the right guy yet. Right now, straight, but open to possibilities. Similar to Dylan, maybe I haven't met the right guy yet. 19-year-old says gay, but had emotional infatuations on females as well before the sex drive began. So he's separating the sexual from the romantic. Another 19-year-old says, I love men. When with a girl, feels great, don't know what I want. Here he reverses it, romantically attracted to men, but there's also some sexual pleasure when with girls. A 20-year-old says, straight but not blind, can tell when a guy is good looking, searching for the asexual perfection. Now, that's a term I would like to explore in more depth with such an individual, asexual perfection. A 21-year-old said, straight, but I don't care about sex, but a loving relationship. Very critical for this individual is who he loves rather than who he has sex with. Actor Josh Hutcherson, an idol of some young people, when he was asked about his sexuality, he said, I would probably list myself as mostly straight, but who knows? I could meet a guy and be like, whoa, I'm attracted to this person. I've met guys all the time that I'm like, damn, that's a good looking guy, you know? But I think defining yourself as 100% anything is kind of nearsighted and closed-minded. And I think in that last sentence, he captures the feeling, the flow of youth today, which is why lock yourself into something 100% when there are options and other possibilities open to you. And that is the essence of fluidity, I think, in many ways. So what is fluidity? It's having the capacity to be flexible in one's sexual and romantic responsiveness across time and circumstances, which allows one to experience changes in one's sexual and romantic desires across both short-term and long-term time periods and various contexts. So it could be day to day, it could be moment to moment, it could be week to week, year to year. That is, the fluidity could change over time or across context. For example, I talked with one young man who said that in a dyadic sexual situation, it's almost always with a girl and he feels straight-ish. But when he's having group sex, then both males and females are there, he feels more attracted with the girls, but he still plays around with the boys. And so in that context, he feels like, well, I'm more fluid than I was in a dyadic situation. It is also important to note that with the concept of fluidity comes inconsistency in attraction, behavior, and identity. This is illustrated by one young man I interviewed who said he is attracted to both sexes, but he has sex with boys but falls in love with girls. And during his lifetime, which has been pretty short, he's identified as gay, straight, bisexual, but now he finds fluid to be the concept that best matches what he feels. Again, inconsistency in attraction, behavior, and identity, which are sort of the three core components that we think about in terms of sexuality. There's also inconsistency across sexual and romantic domains. Even though the two are usually highly correlated, that is, the gender that you are sexually attracted to is usually the gender that you fall in love with. That's not always the case. And a dramatic example of that was with Jacob, a young man that I interviewed. And he said, I've always been attracted to girls in a physical sense. When I see a girl, I want to be with her and I want to talk to her. And I'm initially attracted to a girl. But here's his dilemma. That is, he likes to sexually and emotionally cuddle with a girl. He, at a party, if there are attractive men and women, he'll go straight for the girls. But you'd think he was straight, however, and then, continuing with his quote, for as far back as I can remember, I have kind of been only sexually attracted to guys. And when I asked for details, he says, well, that he can remember from early adolescence that he has always gotten off very quickly and when he watches gay porn. Now, he's 18, a freshman, and I think he wanted the interview to help him clarify what he is. And I will say that he has maintained contact over the years, and he has evolved to some extent to the point where he's now okay with having this discrepancy between his sexual and his romantic self. Of course, his straight fraternity friends say, well, maybe you just haven't met the physically attractive girl that you are sexually aroused by. And his gay friends, because he has several, say, well, maybe you just haven't met the right guy that you can fall in love with. And so he has this dilemma throughout his life of having this discrepancy. So in terms of his sexual self, he says he's mostly gay. But his romantic self, he says he's totally, totally straight. So when you look at the literature on fluidity, it's very easy to find a lot of literature, books, articles on female fluidity. But if you're looking for similar kinds of tracts or writings or articles on male fluidity, you're at a loss because there is very little written about male fluidity. And in fact, a lot of scientists so disbelieve in male fluidity that they don't even measure it or ask questions about it. But when you look at fluidity, there are two different kinds of processes that may be going on. First is biological. So male sexuality, most would say, in terms of researchers, that it is rigid and stable, shaped by genetics or prenatal hormones. On the other hand, female sexuality is biologically flexible, shaped by the environment and the experiences she has. So the idea here is that she might not even have a sexual orientation as we usually think of it, as being straight or lesbian, but that she is fluid. Another way of looking at this is in terms of socialization, sorts of pressures or processes. So it goes without saying that men are usually socialized not to engage other men, at least straight men, we should say, in anything that appears sex-like. For example, there are clear boundaries about men hugging each other. Certainly not a full embrace as they might give to a female friend. Women are given the freedom, maybe even encouraged, to display love and sex with other women. So we have no question when we see two women holding hands, we do not automatically jump to a conclusion about what their sexuality is. But if we saw two men holding hands, of course we would. Thus, combining these two, we say male sexuality is categorical and female sexuality is on a spectrum. Sounds good, but there's one piece of evidence that confuses this to some extent. And that is when you look at the literature and you count up the sort of the percentage of men who have sex with other men, you'll find that the majority of those men identify as straight, not as gay or bisexual. This is illustrated by Brendan Urie, who's a lead singer of Panic at the Disco, another icon of the young generation, who says the following: I find myself being attracted to dudes all the time. I'm like, wow, that's a beautiful man. There's no shame in it. That's how I feel. I guess if I had to classify myself, and this is interesting, if he had to classify, choose a category, he'd say straight. But I have in the past experimented in other realms of homosexuality and bisexuality. Now, what he means by experimented or other realms would be a worthwhile discussion to find out what does he exactly mean by this. But when you ask straight men why they've had sex with other men, they'll say one of the following, or maybe all. It was during innocent, meaningless boyhood play. So it's not important. They were just friends. It was a cousin. It was a neighborhood boy. Or it was during early adolescence. You know how the hormones are during early adolescence. I have sex with anything or anybody. Or he was drunk or high and thus not responsible for his actions. Or he was incarcerated in prison, and so it was not a matter of sex, but a matter of power. Women were not available in an all-male space, such as boarding schools and fraternities, and you can imagine other kinds of all-male spaces. I noted that once when I went to a fraternity party, and the later you stay in the early morning hours, the women begin to leave, and pretty soon all the people who are dancing are males, and even dancing with each other. And then before long, they begin pairing off and going into each other's rooms behind closed doors. What happens, no one knows except those individuals. There's also two concepts, dude sex and bud sex, that has received some amount of publicity lately. Dude sex is when a straight identified man who feels himself to be very masculine feels so straight and so masculine that having sex with another guy doesn't threaten those two. And indeed, he might feel that having sex with another guy proves or demonstrates how straight he really is. Bud sex is somewhat similar, except here it is in a rural or a country setting in which there's not a lot of options. And so two male friends, and maybe they decide, well, we have urges that need to be satisfied, and having sex with each other is a fair way of doing that, and is enjoyable, and they want to do it. By contrast, a young man who is fluid recalls not just these momentary instances or examples of homoerotic nature, but they would say that they have felt changes in their sexual romantic attractions from maybe their earliest memories in childhood all the way to the present. And in this telling, they say neither the homoerotic or the heteroerotic absolutely rules his life, but they come and go in and out of his life. So he does not feel that his sexual or romantic self is static or categorical, but that it exists along a spectrum. And he is surprised that so few other young men, his age or older, feel the same kind of fluidity that he does. He suspects, in some cases, that there are such individuals out there, but still there's such a stigma with a male admitting to being fluid in his sexuality that they are in the closet about their fluidity. Now, there's a larger issue, I think, that is raised with some of these kinds of findings. That is, we expect changes, of course, to occur in sexual and romantic behavior and identity. For example, a gay high school student may only have sex with women and not with men in his school because he realizes he doesn't want the stigma or the harassment that might come if that were to be known. So he might identify as straight, maybe bi, but not gay. That's just too risky for him. However, we do not expect sexual or romantic orientation to change because by definition, it is an enduring, deeply rooted predisposition. And the question for a fluid young man is that he does not feel that he chooses to be fluid, but that in reality, fluidity chooses him. So, is fluidity itself a sexual romantic orientation? That is, a young man doesn't say, let's see, what will I be today? It's not a lifestyle choice. It's not an add-on. He's not gay plus or straight plus, but he feels that this is a sexuality itself, that fluidity is a sexuality coming from deep within himself. That is, he describes it in a way that a monosexual or a bisexual individual might say about his sexual or romantic orientation. Now, we don't know scientifically what causes any orientation, whether it's gay, bisexual, or straight. And so too with fluidity, we're not quite sure what causes it, but it would be interesting perhaps to find out. So, how many fluid young men are there? Well, we don't know. And we don't know because we don't ask. So the actual numbers, very difficult to decipher. I believe that it's not trivial. Maybe it's 10% of the population. I don't know. I do know, and the literature does show, that it's higher among sexual minority individuals, especially among bisexual and pansexual individuals who feel many of them are born with the capacity to freely make choices attuned to sort of their inner desires. My conclusions, and I must add that this is not a consensus of the empirical or theoretical literature, but it's mine. Men are sexually and romantically fluid, I believe, likely in the same way at the same rate as women. They're expressing it now more than ever before, especially among the Z and the millennial generation. We know somewhat that fluidity is highly correlated with curiosity, openness to experience, and sexual and romantic libido that is a little higher than normal. I believe that in both sexes, they start with the same potential for biological fluidity, that is an orientation, and if feminine socialization encourages it and masculine socialization discourages it, as the literature seems to indicate, then we'd expect more fluid women than men. However, one must also note that in our culture, toxic masculinity is decreasing. Didn't say it was over, but certainly is decreasing, and inclusive masculinity is increasing. Then it is possible to think that perhaps male fluidity should be coming out of its closet. And in this, I think we should listen to young adults such as Woody, Cook, Dylan, Jacob, Josh Hutchison, Brendan Urie, and I think especially to one young man I interviewed who was sort of struggling to get me to understand his sexual and romantic orientation. And he finally just stopped and said, well, I'm not 100% sure of what I am, but I'm okay with it. And I believe that this is what we should strive for, that we should try to understand their perception of their sexual and romantic self, to allow the possibility that it might not be static, it might not conform to one of our definitions, but that it is meaningful to him. And I believe this is really the key to what I would like for us all to do when we are talking with our young men, and I might add to our young women as well. Thank you for your time.